Hello, everybody, and welcome again to Shaare Tzedek Medical Center. We are happy to broadcast another case to ICI. We have a very interesting case to show you, and let me show you the team. I'm Danny Dvir, I'm the head of the Cath Lab here, and I have with me Eyal Ben Asa and Ami Harari that working together. We have also Professor Shemi Carasso on the echo. We have a very big team here in the room because we have Medtronic team with the valve. We have PiCardia team with Ronnie here having the shortcut device that we're going to show you in a second. Gidon Perlman, Yafa is the nurse in the case. We have also Elias Mazawi and Karmit Ben Ami, Elias Chilu, my right hand. Okay, so let us show you the details about the case, please.
Hello, ICI. We have a fascinating case today of a complex valve-in-valve TAVR. This is a 68 years old gentleman with a lot of comorbidities. He has diabetes, severe COPD, he has cirrhosis, and 5 years ago he underwent AVR with Magna Ease 21 millimeter. And he has been deteriorating in the last 3 months, hospitalized for severe dyspnea for a couple of times, and we've found that he has severe prosthetic valve deterioration. And he's here with, as you can see, with high Euroscore and STS prom, and we're evaluating him. Next, please. We can see his echo with severe aortic stenosis, gradient of 100/65, normal LV, elevated pulmonary pressure. Next, please. This is his valve, Magna Ease 21 millimeter with true internal diameter of 19 millimeter. This is a small valve for this gentleman. Let's go next, please. His iliofemoral anatomy is good for transfemoral access. And next, please. And now, maybe we can discuss some of the complex of this procedure.
So maybe you can describe the risk for coronary obstruction, please.
Okay, as you can see here, this is the CT analysis. You can see the VTC, the virtual distance between the valve and the ostium of the coronary artery, which is borderline, it's 3.8. And you can see the VT-STJ, the distance between the STJ and the virtual valve, which is low, it's 2.3 millimeters. Next.
Can you go up? Okay.
So maybe we can describe the shortcut device that we're going to use in this case. This is the first dedicated tool for leaflet modification, already in high clinical use under a study. The device has a positioning arm that it needs to sit behind the leaflet, and here you can see the splitting element when it perforates the leaflet at the base. This is a device that is intended to prevent coronary obstruction, and by having a very gentle wire push and gentle device retracting, we are able to slice the leaflet, which this is what we want to do in order to prevent coronary obstruction. So you can go to the next slide. So maybe, Eyal, you can summarize our procedure plan.
Okay, so our plan would be, we'll start with a cerebral protection device with the Sentinel device. It will be followed by the leaflet modification with the shortcut device. Then we will fracture the bioprosthetic valve with an Atlas Balloon 22. And we will end with the valve-in-valve TAVR with an Evolute R 23 millimeter.
So we have a very interesting procedure here. Complex procedure, high-risk procedure, a 68-year-old patient. Eyal, how come this patient is not referred to open heart surgery?
This is a big heart team discussion that we had, but after all, this is a very high-risk patient. He has severe COPD, he has cirrhosis, and we presented him to our CT surgeon.
And a previous surgery.
And a redo surgery, of course, for an AVR. And there's no question with an Euroscore of above 9 and an STS almost 7, and that's what the CT surgeon suggested, and our heart team decided to do.
Maybe we talk about leaflet modification. Maybe we should talk about ring fracture also that we plan to do in this case. Eyal, how come we plan to do ring fracture here?
So this is another matter of debate. But at the end of the day, this is a 68-year-old gentleman, and physiology will determine the longevity of the patient and of the valve. So what we want to achieve is the best hemodynamic of the valve, and we use two tactics. One of them is using a supraannular valve, but one which is very important, this is a 19 internal diameter valve. You put another valve inside, we will end up with a high gradient, and if we want to have this young gentleman good hemodynamic for a long time, we decided to fracture the valve and get perfect hemodynamic results.
Maybe before we're going to actually start the case, Shemi, please go through the echo evaluation of the patient, the basic story here. How
Well,
does
the basic
valve look like?
evaluation of the patient starts with a transgastric view to maybe try to confirm that we have a severe aortic stenosis, which we sure know better from the TT that was done before. And we actually measure the flows in the aortic root in the aorta. And then we proceed to exclude the presence of pericardial fluid because we needed to compare it to what will happen next. It's, of course, one of the risks. And then we can evaluate again the valve. So what we see right now is the short axis of the valve. You can see the leaflets. You can see here that's the left, that's the non-coronary, and that's the right. Here we choose the coronary that is at risk is the left, so we need to focus on that area. And we need to actually, when we'll see if we're able to actually see the leaflet itself, to then make sure that the split is done right. Here we'll have the one of the elements that is going up to the area. We see it is probably opposite to the left coronary. We see the left main here. And of course we have to look with color, as I see put here now, and I'll reduce the velocity as much as I can. And then you can actually see the velocity, I mean, you can see the flow in blue there. Let me show you, it's the LAD flow, which is good. So we know we can mark it, and then we can follow it after the split to see that, and after the TAVI to see that it's not compromised.
And we lock, and
Wire a
we
bit.
just show it like that. So we had a minimal challenge there with performing the sentinel protection. And we are after it. There you go. Okay, so here we can understand the location of the coronary, which is very low indeed, and we have a risk for inflow obstruction, and especially when we're going to plan to do bioprosthetic valve ring fracture in this particular case. There is a basic aortic regurgitation, which is not severe, but it is there. So I think that the next step is to cross the valve. Yeah. Now we're about to do a step that is sometimes the most challenging part of valve-in-valve procedure, crossing the failed aortic bioprosthesis. It's especially more complex when we talk about crossing a small valve and a valve that has some sinuses. No need to do a severe one.
Opa, nice.
Okay, now it goes.
We are
It's in the middle.
close.
Have it?
Okay, now is the time to check the hemodynamics of the valve. So here you go. These are the hemodynamics of this particular valve, and to be honest, I didn't expect it to be so dramatic, right? This is a critical AS patient, right?
It is. No.
And this is the time to bring the shortcut device. The shortcut device goes through a 16 French sheath, and it's just a nice transition before doing the TAVR procedure afterwards, because you can use the same sheath or use the same area for doing the TAVR. And also you have the left ventricular access already from the shortcut, which can easily be expedited for TAVR later on. Thank you, Ronnie. So Ronnie is bringing us the ShortCut device. The distal tip of it has a pigtail shape. Maybe we can put it on the table in a second and show the camera, and we can take the pigtail out of the table.
I have wire.
Okay. So this is the ShortCut device. It has a couple of handles on it, 4 handles, and we will go each one during the procedure. And now I'm just delivering the device through the sheath. Now we are in the descending aorta. Okay. Looks good. So a bit of tension. Bit more tension. Okay, maybe we store the last picture. So there is no doubt that our blood pressure before even intervening is a bit low. Okay. Tension on the wire a bit. Let me see if I can go through that area. Okay. It's not easy delivery, I must say. In this particular case, this is not a common scenario. It is the extreme stenosis and calcification on the valve. Maybe in retrospect, we should have pre-dilated the valve gently before going to this step. Bringing the device. The device will come in by unsheathing it. Like that, right, Ronnie? So the device is being unsheathed. Okay, now it's open for... Sometimes it happens that it needs a bit of rotation before it really comes out. Obviously, you see the device in the ascending aorta, it needs to be rotated to the correct position, which is this one. So now we sit nicely in the ascending aorta. The positioning arm is oriented nicely to be behind the left cusp. Maybe if I do a bit more rotation. Yeah, we're going to bring the device a bit higher. And now afterwards we're going to do some deflection with rotation of the other handle. And now we sit nicely, as you can see, behind the left cusp. So as I said at the beginning, we have 3 posts for bioprosthesis. We have 2 posts of the surgical valve on the right side of the screen. There is a leaflet between them. And we sit with the positioning arm behind that particular leaflet. So in side view, we are in a good position. The question is whether we are good also in the front view. So for that, we need to rotate to severe areo-caudal. Unfortunately, many of the left cusp front views are in severe areo-caudals. And actually, it looks good in that view as well. So fluoroscopically, we are in a good shape. So we're in good shape, Shemi?
It looks like...
Okay, we're back in business. We are in the left cusp side view. Fluoroscopically, we look good. Echocardiographically, we look good. The patient is stable. And probably this is the time to start the maneuvering the splitting element. So we are going to start to activate the splitting element. Nicely done. We can understand that there is a small knife that now was able to puncture the leaflet. In many cases, I do not like to puncture too low because we're close to the ring of the surgical valve, but we cannot be too high because we need to have an effective basilica effect. Even I can say that we are slightly started to cut the leaflet. We are a bit higher than before. Okay, and now we're gonna cut the leaflet. So it's going to be with a gentle push on both the wire and the system. Gentle push. Everything here needs to be very, very gentle. Okay, it's already halfway cut, by the way. I'm on the external side of the ascending aorta, and I'm pushing the wire gently. You see that we are climbing up on the leaflet as we speak. No need to panic in these cases. We are almost out. Gentle push and gentle pull. Here we are out. Okay. So that was a splitting of a leaflet.
Very nice.
So let's store that.
You have a new AI.
Okay. We'll put it in the inner arch. Fortunately, the patient is stable. We're going to keep the wire in the LV, remove, just a second, we'll continue shifting a bit more. Okay, keep the wire in the LV, Ami, looks good.
Okay.
Looks good. We have a big sheath and we have a wire in the left ventricle, so we're good to go with the next steps of the procedure. And did we
prepared it.
When we talk about biprosthetic valve ring fracture, in order to generate a lot of pressure inside the balloon, we will, as in all of the previous cases, we're going to inflate the balloon with a big syringe and later on use an end deflator in order to generate high pressure. We have a three-way stopcock that will go between the syringe and the end deflator. And we're using, in this particular case, Atlas 22 millimeter balloon. It's interesting, we see that the pacing increased the blood pressure. We always are fascinated by the fact of how pacing improves hemodynamics in AR. Shemi, maybe since the patient is stable, maybe we will have a quick look, if you're ready, to understand what we got after doing the leaflet modification.
We got a new AI, which is very significant as an acute AI with the very nice slope.
So significant AI
Significant
is
AI,
very
of course the
important signal
AS,
that we
the
did
AS of
something.
course is not changed. Okay, now we'll go to short axis and see if we can actually see the split. And we actually can see it.
Okay, so Yafa, it's going to be 180 in a second. Guys, you all ready?
Yes.
Okay. So, pacemaker on. Okay. Go. Fill it up, fill it up, fill it up, fill it up. Nicely done. Switch.
Okay.
Go.
I'm
20.
going.
Go to 20 quickly.
We are in 20.
Okay, it's a long rapid pacing. Okay, it burst. Okay, go down. Okay.
I didn't see.
Stop pacing. This is a very long rapid pacing. We will need to quickly deliver the valve.
Did it burst?
Guys, give the patient some inotropes. Clearly the valve is dilated dramatically more than it was before.
אנחנו צריכים את המסתם?
We're going to deliver the Evolut device now.
You should remember that commissural alignment and the height is something important
Yes, it's
here.
always a part of leaflet modification procedures is how you do the valve. It's not only cutting leaflets. So leaflet modification is important. We see that the top hat is in the outer curve, which is where it needs to be.
And our target going to be 4.
And the target needs to be a bit deeper than conventional TAVR procedures.
Okay. Start
Okay. Okay.
deeper.
Continue more. Okay. Yes, you're right. A bit deeper. Yeah.
Okay.
We'll do a short cine here. Okay.
Okay.
Let's do we are in no rush.
Nope.
No rush. Okay, you can continue
Starting.
gently. Yeah. This is around 4-5 millimeters depth. Our target here is not to be 0 or 2, but to be between 4 and 8 in this particular case, or else we're going to obstruct the coronary flow very gently now.
Okay, let's go to the...
Yeah. Go to 70%. We are not fully aligned to the valve. Okay, blood pressure is coming back. Look how nicely the blood pressure came back after deploying, because there was a significant AR, obviously, right?
we can pace him maybe in 80 right now.
Go.
You want?
Yeah. Yeah, or maybe even stop pacing and see what happens. Nicely done, guys. So, blood pressure looks good. Shemi, what do you say about
looks good.
looks good? Also the valve?
Yeah.
There's spacing.
Okay, please do it very slowly. There is no rush whatsoever. No rush. We'll take it over 2-3 minutes.
Yeah. Let's wait a second.
Yeah,
Let's give it
yeah, absolutely. Gently. So the rapid pacing stabilization during evolute procedures really became a common strategy in order to stabilize the device.
I'm not sure.
Yeah, I think we're still connected, maybe.
The last one is still connected.
So gentle rotation on the device.
Yeah.
Nothing changed. Gentle push-pull. Let's see.
Yeah.
Okay, now it's released. Okay. Okay. Shemi, maybe you can give us an overview with the valve. There is still a pigtail through it.
Yeah, there's almost no AI.
Okay.
And the gradient now,
PiCardia.
peak is 6, mean is 3.
So until Shemi will give us the final verdict about this particular case, we can say many things. First, that the shortcut steps were very, very quick and easy, right? Yes. We didn't need even to manipulate it too much. The BVF was complex. So BVF is still a procedure associated with some hemodynamic instability, especially when we do it pre-valve-in-valve BVF and not post-valve-in-valve. But yes, please, Shemi.
Beautiful function.
When the echo person says beautiful, we are extremely happy.
Septum are very nicely contracting. The valves disposition very nicely. There is no AI at all.
So
the circumflex and the left LAD.
Inject.
And you have beautiful flow.
Okay, we have a nice flow to the coronary. Okay, so Eyal, Ami, Shemi, we were very happy to see that very ambitious plan that we had to do a shortcut, right? I almost said basilica. A shortcut procedure followed by bioprosthetic valve ring fracture. Looks that the patient is stable, and hopefully the patient will have longevity with this very nicely expanded device.
I think we gave him the best hemodynamic and solution for coronary and physiology that he could have got. Very nice.
Okay, so thank you all, and we're happy to be here, and see you in the next live case.
Thank you very much.